Imagine walking into like a really high-end, beautifully lit clinic for a quick cosmetic laser treatment. You've been dealing with some pelvic discomfort, maybe some dryness related to menopause, and the brochures promise the simple, high-tech rejuvenation.
Right, a quick 15-minute fix.
Exactly. You expect to leave feeling restored, but instead you wake up weeks later to find the tissue permanently scarred, your anatomy literally altered, and you're dealing with this chronic, debilitating pain.
Yeah, and it sounds like a horror story, but it's not hypothetical at all.
No, it's not. It is a very real, heavily documented outcome that happens when modern cosmetic technology violently collides with an invisible, undiagnosed autoimmune condition.
And, the only thing standing between a patient and that catastrophic outcome is often this tiny, seemingly obscure detail on a pathology report, like a microscopic warning sign that the naked eye can't even see.
So today, for you listening, we're doing a deep dive entirely on that specific warning sign. We are looking at the clinical significance of a baseline biopsy showing something called basement membrane zone thickening.
Or BMZ thickening, for sure.
Right, BMC thickening, discovered right before a patient is scheduled to start an energy device protocol, like a vaginal laser. And to map this out, we've pulled a pretty heavy stack of medical literature today.
We really did. We've got clinical guidelines from the British Society for the Study of Vulval Disease, the BSSVD, and ICC in the UK.
Yeah, and we're also pulling from consensus statements from the American Urologic and Ecologic Society, plus these incredibly detailed dermatological FAQs published by the Women's Health Clinic.
And, the overarching theme across all these sources is really this massive clash of paradigms. We're basically watching microscopic cellular pathology intersect with a multi-million-dollar commercial wellness industry.
Which is wild when you think about it.
It is. Because these cosmetic devices are aggressively marketed as quick fixes for complex symptoms. But if a clinician doesn't actually understand the cellular foundation of the tissue they're treating, they are flying completely blind. And the results can be devastating.
So let's start at the very beginning of the patient journey then. Because before we can understand why an energy device could cause so much damage, we have to translate what the pathologist is actually seeing.
Right, we need to decode the jargon.
Yeah, exactly. So if a patient gets a baseline biopsy and the report comes back noting, basement membrane zone thickening, what is actually happening in the body?
Well, first off, BMZ thickening is strictly a pathology concept. It is not a symptom you can feel or point to.
Okay.
What the pathologist is looking at under the microscope is a key indicator of the early or transitional phase of a chronic inflammatory skin condition called lichen sclerosus.
Often abbreviated as LS, right? That term shows up in nearly every single source we have today.
Yeah, lichen sclerosus is the main culprit here.
But, the literature describes the classic presentation of this disease as causing severe dermal sclerosis, which is like heavy scarring.
Extremely heavy scarring, yeah.
Right. And it causes the tissue to become incredibly thin, taking on this crinkled cigarette paper appearance. It can even cause the labia to fuse together. So if that's the disease, why are we talking about a thickened membrane? That sounds like the total opposite of thin scarred tissue.
That paradox is exactly why this disease is so treacherous,
Okay.
In its classic late stage, you absolutely see all that severe scarring and thinning. But in the early stage, that classic architectural damage isn't there yet.
It's just hiding.
Exactly, it's hiding. Instead of full-blown sclerosis, the pathologist looks at this early tissue and sees three distinct things. They see interface dermatitis, epidermal hyperplasia, and marked thickening of the basement membrane zone.
Okay, we definitely need to slow down and translate some of those terms. Because interface dermatitis, that just sounds like generic skin irritation. What is actually happening at the cellular level there?
So think of the skin as having two main layers, right? You have the epidermis on top, which is your outer shield, and the dermis underneath, which holds the blood vessels, nerves, structural proteins, all that.
Okay, top layer and bottom layer.
Right, and the boundary where those two layers meet is the interface. Interface dermatitis means the body's immune system has sent this massive army of white blood cells to aggressively attack that specific boundary line.
Oh, wow. So it's an active autoimmune attack. What about epidermal hyperplasia then? Because the word hyperplasia usually means cells are rapidly multiplying, right?
They are, yeah.
Hmm.
Because the top layer of skin is under attack from its own immune system, the epidermis tries to defend itself by rapidly multiplying its cells.
Like it's trying to build a callus or something.
Exactly like building a callus. It becomes super hyperactive. And the basement membrane, which is the structural glue holding the top and bottom layers together, it swells and thickens in response to this really intense localized warfare.
So, if we think of the basement membrane like the physical foundation of a house, an inspector coming in and finding a swollen or artificially thickened foundation means the house is under intense structural stress.
Yeah, that's a great analogy.
The ground is shifting, basically. The walls haven't cracked yet. The house hasn't collapsed into that late stage scarring, but the early warning system is flashing red.
That structural stress is the perfect way to look at it. And catching this early warning system is incredibly rare because lichen sclerosis is notoriously underdiagnosed. I
Mhm.
mean, our sources really emphasize that patients frequently spend years being misdiagnosed.
Yeah, I saw that in the guidelines. Patients are often told they just have like generic dermatitis or chronic thrush or a stubborn yeast infection, or honestly, it's just dismissed entirely as a normal symptom of menopause.
Oh, absolutely. A patient can be prescribed over-the-counter antifungal creams for a decade with zero improvement because fungi just aren't the problem. Autoimmune inflammation is the problem. So getting a biopsy that reveals BMZ thickening provides the definitive clinical correlation a doctor needs. It lets them abandon the yeast infection theory and actually recognize the autoimmune reality. It's a huge diagnostic victory.
Which brings us to the intervention. So we know the tissue is structurally stressed and under an autoimmune attack. But the entire premise of our deep dive today involves a patient seeking out an energy device protocol.
Right, the lasers.
Yeah. Why are these devices so popular for pelvic symptoms, and what are they physically doing to the tissue?
Well, energy-based devices, or EBDs, have seen just a staggering boom in popularity. The main technologies we're looking at are CO2 lasers, erbium YAG lasers, and radiofrequency devices.
Okay, and what are they actually marketed for?
Commercially, they are marketed to treat vaginal laxity, genitourinary syndrome of menopause, which is often called GSM, and painful intercourse.
The marketing materials use the word rejuvenation constantly. Like they make it sound like a magic wand that just restores youth to the tissue. How does the wand actually work, biologically speaking?
Well, the mechanism is entirely thermal. These devices deliver highly controlled fractional heat into the superficial layers of the tissue.
How much heat are we talking about?
We are talking about the temperatures usually calibrated between 45 and 60 degrees Celsius.
Wait, that is extremely hot. That's like up to 140 degrees Fahrenheit.
It is, yeah. And the heat is completely intentional. The goal is to cause micro-injuries in the tissue. The laser creates these tiny columns of thermal damage, leaving small areas of healthy tissue around them.
Oh, I see.
Yeah, this thermal trauma is designed to trigger the body's natural wound healing cascade.
So the body basically registers the burn and sends in the construction crew.
Yes, exactly. In the first few days, the heat causes edema, so localized swelling. Then it stimulates fibroblasts.
Fibroblasts are the cells that build collagen, right?
Right. They are the cellular workhorses that build our tissue's structural framework. When they're stimulated by the laser, these fibroblasts are supposed to jump into overdrive, leading to neocollagenesis, the creation of new collagen, and neovascularization, the sprouting of new blood vessels.
So the theory is that you use the body's own repair mechanisms to remodel and tighten the tissue.
That's the commercial pitch, yes.
Okay, I need to pause you there, though, because as I was reading through the stack of research on this specific mechanism, I ran into a massive contradiction. And I'm hoping you can, reconcile this for me.
Sure, what did you find?
On one hand, there is a consensus statement from the British Menopause Society, and they claim the risk of thermal damage with these CO2 lasers is illusory. Their argument is that the laser specifically targets moisture in the tissue, so the heat dissipates safely before it can cause a severe burn.
Right, I know that statement.
But in the exact same stack of sources, there is a major 2018 safety warning from the FDA. And the FDA states outright that these same devices are causing severe burns, permanent scarring, and chronic recurring pain.
Yeah, it's a huge disparity.
How do we square that? I mean, are these devices safely targeting moisture, or are they burning people?
We reconcile that by looking at the assumptions built into the technology. You have to remember, the laser beam itself is just a tool governed by physics. The British Menopause Society's stance relies on the assumption of healthy, highly estrogenized tissue.
Meaning tissue that has normal water content?
Exactly. Normal water content and a fully functional healing cascade. If the tissue is healthy, the water absorbs the energy, the fibroblasts remodel the collagen, and the risk of a catastrophic burn is pretty low.
But the FDA warning is looking at the real-world application where that assumption fails.
Precisely. The danger lies in patient selection and, really, the aggressive commercialization of the devices. The NICE guidelines in the UK are very clear about this. They state these energy devices should never be used routinely for laxity.
Right, they mandate conservative care first, right?
Yeah, things like pelvic floor physiotherapy or localized estrogen therapy must be the first line of defense. The FDA warning exists because these devices rely 100% on a normal physiological healing
And
response.
if that response isn't normal,
If a patient's tissue is compromised, like if the cellular construction crew is broken, the heat won't rejuvenate anything. It'll just cause raw, unmitigated damage.
wow. Okay, so if a patient with that thickened basement membrane, that early warning sign of lichen sclerosis, walks into a clinic and sits in the laser chair, what actually happens? I mean, we have a system already under autoimmune attack, and we add 140-degree fractional heat to it. What is the biochemical collision taking place there?
This is the core clinical significance of our entire topic today. If a patient has BMZ thickening, they have early-stage lichen sclerosis. And lichen sclerosis completely alters the skin's collagen mechanics and its baseline immune function.
Oh, so.
The sources detail how LS tissue is basically trapped in a state of intense oxidative stress.
What does that mean practically, though? How does oxidative stress change the tissue before the laser even fires?
At a cellular level, oxidative stress means there's an excess of free radicals. These are unstable molecules just ping-ponging around the cells.
That doesn't sound good.
It's not. These free radicals tear apart lipids in the cell membranes and can even mutate cellular DNA. This is called lipid and DNA peroxidation. But honestly, it gets worse.
Worse than mutating DNA.
Yeah. The sources also highlight that LS patients have circulating IgG autoantibodies, specifically targeting a protein called extracellular matrix protein 1, or ECM1.
Extracellular matrix. That sounds like the scaffolding of the tissue itself.
It absolutely is. ECM1 acts like the mortar holding the biological bricks of the skin together. It regulates collagen bundles and blood vessel formation.
Okay, so the mortar is crucial.
Very. And in a patient with lichen sclerosis, the immune system is actively dropping bombs on its own mortar. The tissue's ability to heal, to regenerate, and to properly remodel collagen is fundamentally broken.
So it's basically like taking a blowtorch to a suspension bridge where the steel cables are already heavily rusted and failing.
That is a terrifyingly accurate way to picture it.
Right, the clinician thinks they are heat treating the metal to make it stronger and tighter. But because the underlying structure is already severely compromised by the rust, the intense heat just causes the entire bridge to collapse.
That is the mechanical reality of what happens. And dermatology actually has a very specific term for this disastrous reaction, which is highlighted in the sources from the Women's Health Clinic. It's called the Koebner phenomenon.
Koebner, the Koebner phenomenon.
Yes. It is a really well-documented event where physical trauma to the skin forcefully triggers or violently accelerates an underlying inflammatory disease. We see it in conditions like psoriasis and vitiligo, but it is highly prominent in lichen sclerosis.
So the physical trauma of the laser basically acts as a homing beacon for the autoimmune disease.
It literally rings the dinner bell for the immune system.
Hmm.
If a clinician ignores the BMZ thickening on the pathology report, or, skips the baseline biopsy entirely just to rush into the cosmetic procedure, they apply that thermal trauma.
And the body registers the massive heat injury.
Right. But instead of sending in healthy fibroblasts to rebuild collagen and rejuvenate the tissue.
The body sends in a hyper-aggressive wave of white blood cells and autoantibodies.
Exactly. It floods the zone with inflammation. The laser acts as the ultimate Koebner trigger. So instead of a mild tightening effect, the device accelerates the patient straight into severe scarring lichen sclerosis.
And the literature is brutally clear about what severe LS looks like. We are not talking about a persistent itchy rash here.
No, not at all.
We are talking about architectural obliteration of the patient's anatomy. The labia minora can completely resorb, essentially disappearing into scar tissue. The clitoris can become entirely buried under a thick layer of sclerosis, which physically suffocates the neurovascular blood flow and destroys orgasmic function.
It is a devastating, life-altering outcome, and it is completely 100% preventable if the clinician just understands the clinical significance of that single microscopic finding, BMZ thickening.
Because the biopsy proves the tissue is a powder keg.
And the energy device is the match.
Right. So we've established the nightmare scenario. If a clinician actually does their due diligence, does the biopsy, and sees the BMZ thickening, how do they pivot? Because obviously they have to cancel the cosmetic laser package.
Immediately, yes.
But they can't just send the patient home to deal with autoimmune disease on their own. What does the evidence-based care plan actually look like?
Well, finding that thickened basement membrane demands an immediate shift from a mechanical cosmetic intervention to a strict medical protocol. The primary goal is no longer collagen production.
Right, the goal changes entirely.
Exactly. The sole objective now is suppressing that localized immune chaos.
And the sources outline the gold standard treatment for this, which involves ultra-potent topical corticosteroids. A specific one mentioned heavily in the literature is clobetasol propionate.
Clobetasol is highly effective. Alternatively, for patients who cannot tolerate steroids, clinicians might use topical calcineurin inhibitors like tacrolimus.
How do those work?
Calcineurin inhibitors work by specifically blocking the communication signals of T cells, basically preventing them from launching the immune attack in the first place.
I can imagine a patient being hesitant about long-term steroid use, though. I mean, we are generally taught that potent topical steroids will thin the skin and cause damage over time. Isn't that counterproductive for a disease that ultimately causes thin, fragile skin?
It sounds super counterintuitive, but it's a fascinating paradox in dermatology. Healthy skin will absolutely thin out if you chronically apply an ultra-potent steroid.
Eee.
But lichen sclerosus skin is heavily infiltrated by inflammatory cells. It's artificially thickened by this autoimmune war zone. So when you apply the steroid to LS tissue, it acts as a fire extinguisher.
Oh, I see.
Yeah, it stops the white blood cells from attacking that ECM1 protein we talked about. By shutting down the inflammation, the steroid actually allows the skin to return to its normal, healthy thickness and function. It rescues the tissue architecture rather than degrading it.
Which really proves why this deep dive is so critical, even if you, the listener, don't have a medical degree. It shows why we just cannot allow complex pelvic symptoms to be reduced to simple marketing buzzwords like laxity or dryness.
Completely agree.
The commercial industry wants patients to believe their bodies just need a quick, expensive technological tune-up. But demanding thorough clinical assessments and, insisting on a diagnostic biopsy before jumping into a thermal procedure can literally save a patient from irreversible harm.
And the stakes extend far beyond just preserving sexual function and anatomy, as crucial as those are. The sources highlight that lichen sclerosus carries a darker long-term consequence.
The cancer risk?
Yeah, patients with LS have up to a 3% risk of developing squamous cell carcinoma, which is a type of vulvar cancer.
3% is a massive number when we are talking about oncology risk profiles.
It is incredibly significant. The chronic inflammation and rapid cellular turnover basically create an environment ripe for malignant mutation.
So treating it early is vital.
Crucial. By catching the disease early, in that BMZ thickening stage, the clinician isn't just preventing a severe Koebner reaction from a laser. They're initiating lifelong surveillance.
Right.
When LS is managed correctly with long-term topical steroids, clinicians can push the patient into complete asymptomatic remission. They suppress the oxidative stress, preserve the architecture, and actively lower that 3% risk, potentially preventing a future cancer diagnosis entirely.
It is a remarkable journey. I mean, we started this deep dive looking at a microscopic anomaly, right? A swollen basement membrane that no patient could ever feel or see.
Just a few words on a pathology report.
Exactly. But by understanding the mechanics of that swelling, it acts as a crucial invisible shield. It forces the clinician to stop a potentially disastrous heat-based cosmetic protocol, and it redirects the patient toward life-saving, evidence-based medicine that preserves their anatomy and guards against cancer.
It's the ultimate testament to why pathology and evidence-based clinical guidelines must always dictate care, regardless of how aggressively a new cosmetic technology is being marketed.
Absolutely.
But, as we wrap up this analysis, there is a small detail buried in the pathogenesis section of our sources that points toward a very different future for this whole field.
The pathogenesis section, so the part covering where lichen sclerosus actually comes from.
Yes. The sources note that while the exact cause of LS is unknown, it is an immune-mediated disease heavily influenced by specific genetic markers, specifically HLA class II alleles.
Okay, genetics.
Furthermore, emerging research actually ties the severity of these autoimmune reactions to systemic inflammation and the health of the gut microbiome.
The genetic and microbiome connection. That's fascinating.
Exactly. Which leaves us with a highly provocative thought regarding the future of cosmetic dermatology. If conditions like lichen sclerosus are secretly brewing in the background, dictated by our genetic code and our gut flora, just waiting for a physical trauma to trigger them,
Right.
how long can the aesthetic industry continue to operate blindly? Will we reach a point where the standard of care requires a clinician to sequence a patient's microbiome or run a DNA panel for HLA alleles before they are legally allowed to power on a laser?
Wow.
Because if we know certain genetic profiles are predisposed to the Koebner phenomenon, Applying unmitigated thermal trauma without checking their DNA first may soon be viewed as archaic and, frankly, negligent.
It really makes you wonder how many bad reactions or mysterious complications from routine cosmetic procedures are actually just undiagnosed autoimmune conditions reacting exactly the way they were genetically programmed to.
It's a huge question for the industry.
Well, that is all the time we have for today's analysis. Thank you for taking the time to explore this complex intersection of pathology and technology with us. Keep questioning the science behind the glossy marketing brochures. Always look for the biological why behind the clinical what. And remember, sometimes you really do need to investigate the foundation before you authorize a remodel. See you next time.